So Dr. Christoph Correll, it's such a pleasure having you here for our interview with the ACAP Abramson Grant, where it's time for us to kind of hear about your career in research. So I was hoping you could start off by walking us through the journey of how you got into research, how you found your area of interest, and how it all started.
Well, that's a great question. Basically, I always was interested in both the literature and philosophy, history side, but also the basic science part when I was in school. And I thought the combination was really going into psychiatry. So I pretty early knew I wanted to do medicine and also psychiatry. I also have a little bit of a genetic loading. I have 4 psychoanalysts in my family,
Wow.
4 psychoanalysts, but fortunately they're not my parents, so they didn't alter my behaviors too much. But that meant the idea of doing something psychiatrically was not alien to me. And then in medical school, when we had a shortage of nursing staff, basically that dictated that lots of medical students had to do night shifts. And I did that on a locked male unit at the university, the Free University when in Berlin, when it was still separated in East and West Berlin. And I saw very sick, very psychotic patients that I was basically guarding to not hurt themselves or others. And that piqued my interest in really psychosis. And I had a naive hope that I would A, understand psychosis and schizophrenia, and B, cure it. I'm much less naive and a little bit more knowledgeable now that this is not possible. But going into medicine, I felt I wanted to understand the brain and help that. Now, part of the German system is also that you are not called a doctor. I'm German originally, grew up in Hamburg, studied in Berlin, and then went to the US. So basically, to be called a doctor, you need a dissertation. And so that dissertation also got me into obviously doing research. But part of the German system was also that you needed to do a final year where you have medicine and surgery, but also an optional course. I told you I wanted to be a psychiatrist, so I did the optional course in New York, and I felt I needed to go to the US, but wanted to do research. And since I never would become an internist or a surgeon, I went to Chile for that because I wanted to learn about another medical system and also the language and Spanish a little bit more, which was tough to basically treat patients day one, but I understood that after a while. But in the US, I was taken by the system that, wow, you're basically entering a training program where the training program is responsible for making you a specialist. In Germany, it's different. You are responsible to making yourself a specialist, and you may go from hospital to hospital, and maybe you have a good supervisor or not. So then when I came back to finish my courses, and I could have gone to the US, but I had a standing invitation after my rotation there. The problem was that at that time, you couldn't go directly, you wouldn't become a fully licensed physician. You were partially licensed for a year and a half to save money for the system. So that meant I couldn't go to the US right away because they only would accept someone from outside who is a fully licensed physician.
Got it.
And also there's a little bit of a wrinkle to become a psychiatrist in Germany. You need to have 1 year of neurology. And to be a neurologist, you need 1 year of psychiatry because there's the feeling that it was intersecting quite a bit. And I knew in the US it would only be 2 months of neurology and 4 months of medicine. So I went into neurology first. And since I had this legacy of 4 psychoanalysts, I felt, and my middle name is after an uncle of mine, a brother of my father, who founded a new psychoanalytic school. I felt, am I running away from medicine? Should I not really try this hard? So I went into neurology and even intensive care neurology, 2.5 years, because at that time, with 3 years, you could become a big nerve doctor to do neurology and psychiatry. But I said, no, I want to be a psychiatrist. I really want to understand psychosis.
Uh-huh.
And so after having done that, I then finally went to the US. And well, I should say before going to the US, in terms of research, I did my dissertation in Germany and had a very bad experience. So in Germany, we call our supervisors not just supervisors, they are doctor fathers. For a doctor dissertation, they're really like fathers or mothers. This was not a father at all. Basically, he took the data I collected and published them himself. When I then wrote 2 papers, he never looked at them. They were never published at first. And then when I was in the US, finally, I did a PubMed search and found a paper of mine. So it was really horrible. So I went to the US and thought, okay, I had done neurology. I came after the match date. I had no idea that there was a match date, so I could have gone to Cambridge, or I only applied on the East Coast because I knew I wanted to do research. I wanted to go to the US, but only do my academic training, like become an adult psychiatrist, and then go back with a little bit more research standing.
Right.
And applied in Boston and New York, basically. And then chose Beth Israel Medical Center in New York, because there was a guy who had written a neuropsychiatric textbook. And I thought, okay, now neurology and psychiatry would come together. There was a research fellowship set up with him. But again, I knew what a bad mentor was. I wanted to research with him. I was a first-year resident, and he was doing these neuropsychiatric rounds on neurology units, looking at very fancy symptoms and brain expressions of when something is not working well, how it basically behaviorally expresses. So he was going on to this round with his entourage of people. I was the small first-year resident. And so he was examining someone and said, well, this is because of that. And then I'm not entirely dumb. I had done some research on the paper already in neurology, and also some experience in neurology. And said, well, why don't you examine this to rule out that? And then he did this in front of everyone. And I thought, okay, I know bad mentors. I'm supposed to be a research fellow next year. And you're telling me to be silent in front of everyone, although I'm raising a question or I'm making a suggestion. You can tear me apart in front of everyone. The pyramidal track goes that way. What are you talking? But just silencing me because you are the one-man show. I knew this was not my research mentor. So the second bad experience, I'm verbose, but I'm going somewhere. You asked me my path in research. So the first one was I wrote a thesis. The papers were never read. They were then published without my input. And I didn't have really good mentorship. Then this person who was supposed to be my mentor silences me, and I feel this is not the right thing. But then I meet first-year resident. I want to do research. I go basically to a research meeting in New York, and the person who had interviewed me, the person who was supposed to be my mentor, was on vacation when I interviewed for that residency spot. So I never got to feel who he was, but his fellow who graduated and was his research fellow sang high tones about him. And I met her at that research meeting. And she had left that institution and went to Zacher-Hillside Hospital, where I then have been since then, 27 years now. And so I met her and said, oh, well, how are you doing? She said, oh, how are you doing? But then she got beeped because she was on call, and said, well, I can't talk to you right now, but why don't you go to this group of people who are from my new hospital, Zacher-Hillside Hospital in New York? And who do I meet? The chairman at the time, John Kane. And he sees something and he recruits me away as a first-year resident into his program, and the rest is history. Then I had a mentor who was really interested in me, who set me up with certain circuits of people, introduced me to his network, basically, and also got me, since I wanted to research, right into the first episode program. That's what was interesting to me. I wanted to prevent and help people getting worse. So first episode, then I saw first episode is too late. Once it hits, it really is already a lot of psychosis and downstream effects. So I went then into our prodromal clinic, which is the REF program. And that's why I became a child psychiatrist in addition to adult psychiatry. we need to prevent. And I went to my mentor, John Kane, and asked him, what would you do in my third year or even second, if you were in my shoes, where would you go from here? And he said, I would become a child psychiatrist. We need to prevent. So I then was seeing adolescents already in the prodromal clinic as a second-year resident and onwards, then did my child fellowship to do prodromal research in psychosis. Then we saw that in psychosis, people actually also turned out to have bipolar disorder. And we found that antidepressants might prevent psychosis by maybe increasing BDNF, but they can kick people into mania. Then I developed my field of not just psychosis prodromal research, but also high-risk bipolar research, became the medical director of the RAP program, and then developed my own psychopharmacology research in efficacy and safety of antipsychotics. And that's where it was interesting, because I was now dealing with adolescents that had very heterogeneous expressions of symptoms, because they were clinical high risk with anxiety, depression, OCD, not yet psychosis, but that psychotic-like symptoms. They got antipsychotics in the late 90s, where we thought, oh, aripiprazole is so safe. And we saw in youngsters, when you had antipsychotic naivete, these agents had a lot of side effects. So that's why I then became very interested in the risks of antipsychotics and the benefits of antipsychotics in people who had very little experience with them. And that became one of my areas of interest, in addition to prodromal research and prevention of psychosis and mood disorders. What is the side effect profile of antipsychotics, and can we reduce that? Weight gain, metabolic abnormalities, neuromotor side effects, tardive dyskinesia. So physical health and mental health, and neurology and psychiatry. So I came somewhat back with the tardive dyskinesia research to my early roots and was broadening it. But then I became very interested in dopamine as a compound or as a neurotransmitter in the brain. And I remember a career development event with David Kupfer in the early 2000s, when he asked everyone, what's on your t-shirt? What is your topic? And I said, well, can I have a backside and a side? Oh, what's on your freaking t-shirt? And I never adhered to that. I know in the US, you should be very, very focused on just one thing and become the expert. But I do adult psychiatry and child psychiatry. I do psychosis and mood disorders, both mania and depression. I'm interested in dopamine, so it's also aggression and autism and irritability and ADHD. I do efficacy and safety. So that made me a very well-rounded psychopharmacologist, but maybe hard to define in the sense of the very reductionistic pathways that many researchers have. But on the other hand, I'm a clinical scientist. So for me, where the rubber meets the road means I want to understand the brain, but also what's the link of treatments, either pharmacological or also psychosocial, for patients to have a better outcome. And that link is more important to me than understanding the genetic or brain imaging or other determinants of the illness. I want to be informed by that, but that's not my main research. My main research is really clinical psychopharmacology and clinical recognition and prevention research, because I feel I want to be still a psychiatrist and child psychiatry. Transitional psychiatry is important to me, where it bleeds over from adolescence to adulthood. So trying to really capture patients where they are. And for that, I've also been then interested in carving out new instruments. So if you're on the frontier of how you assess prodromal symptoms in bipolar disorder, when I started in the early 2000s, people felt there is no prodrome to bipolar disorder. It only exists in schizophrenia. So we had to create a scale for that and then implement it and assess people. So measurement-based care became very important to me too, because the prodromal field was new, and symptoms of physical symptoms and psychiatric symptoms together were new. So also trying to understand the clinical part of it and including measurement into this, both for psychiatry research, but also for child psychiatry and adult psychiatry clinical practice. So this practice-based research is something that is very important to me, and it has become my identity, basically.
Right. And it's so amazing hearing how you went, like, even from before medical school to now and all your interests. And it really sounds like, as far as your journey goes, things happen very organically. Like, you were interested in psychosis, and then from there, I guess the way that some of the interests were built were in how you see the impacts of treatments for your patients, like going into bipolar disorder and then looking at side effects and things like that. So it sounds very organic. I was just wondering, though, with having all these interests and having done so much research, even starting in residency, what some of the challenges were that you faced and how you, like, worked through those challenges. And I mean, one of the biggest things that I think are on, like, trainees' minds are, like, time constraints, and also, like, how to find a mentor, how to even get a research study started. So can you kind of share about challenges you faced in different phases of your training, like residency, fellowship, and then your career, like your early career professional, no, early like when you first got out of fellowship and then beyond.
Yeah, so the only organicity is really the fluidity of different research aspects and clinical aspects blending together and informing each other. But my career path was not organic. It was very discontinuous and had to really be mended to become fluid by determination and basically persistence. So I told you that my first doctor father was not very fatherly. So I had a
Right.
very bad experience. The second mentor that I was matched with in my first year of residency was not interested in me. When I said I was leaving the program, he just turned around and walked away. He didn't say a word.
Oh.
So people who are very much interested in themselves. And then even when I went into the institution where I've been for the last 27 years, I was matched with people who were not very productive, 1 or 2 papers a year. So I wouldn't be, even though I wanted to research, they wouldn't put me first, and it was very slow. And then I was in another program where people were very possessive and were not so keen on helping someone who was smart, and maybe they felt something was taken away from them. So I was only getting side effect data because I was the doctor, the others were the psychologists. And then I took those and ran with it and created my own, but I didn't get much support in the beginning. So, and I didn't have grants. So what did I do? I took on medical students. There was a Stanley Fellowship, and they worked with me for 12 weeks, and I did chart reviews. I did shoestring research without any funding in order to get my name recognition. So I wrote every paper I could get, every opportunity when someone who was not maybe my mentor, but who got an invitation to write a review paper, I wrote it. I wasn't good at it in the beginning. I mean, we are not trained in medicine to be good researchers. We have to actually do it. We were trained in so many clinical things, but PhDs are much better trained in research and statistics and everything. So I think my going at it and trying, and my first paper was much too detailed and much too long, and I thought, oh my God, everybody will see my introduction. If I'm missing one reference, that's horrible. And I was stopping myself from flourishing. And then what helped me a lot were a couple of things. Doing research with not much money, like letting your clinical sense guide you as a clinical researcher, at least. Where are the questions? Where an attending can't give you the answer, maybe a textbook or even PubMed can't give you the answer. That's a research question. So collect the data with patients, and data that you have routinely. I was very fortunate to work with a professor in medicine who didn't have much of a research career, but had good ideas. He had many ideas, but wasn't detail oriented. I was detail oriented. And we basically worked together and created the Hillside 1000 sample, where we look at 1000 consecutive admissions and make sure that everybody got blood pressure and blood sugar and lipids measured. And then we had basically a community sample in this hospital. So doing things with limited resources, but writing it up, getting it done, following through, having medical students who do child research. So for example, I was I was a clinical fellow in child psychiatry and had to do duty in the emergency room. And I wanted to do research, but there were all these patients that I felt didn't need to be there. Why are you here? You don't need to be admitted. Well, the school said they toppled over a chair and they wanted to have clearance. And I was really getting angry because I'm wasting my time and their time. And I thought, okay, let's turn anger into a research question. Where did the system break down? Why are they here? So I took 1,000 assessments of in the emergency room, and we coded acuity and severity and their pathway to care, and showed that basically the school should have an extra system and not send people right away to the emergency room. But that was basically just a quick IRB chart review kind of a thing, and it grew out of my basically clinical daily routine. And also, at least when I see these patients, I don't have to be so bogged down that I'm wasting my time and their time. No, I'm collecting data right now. So that made me feel much better. And then the other thing was, again, I told you that I was much too detail oriented in my writing and didn't know what was really relevant, but I also became a reviewer. And being a reviewer of papers is really helpful, because you see how experienced reviewers actually pinpoint what's relevant. And then you also feel that's what I need to do when I write. So it's not really the introduction, it's the methods and whether you follow through and whether the discussion hangs together. And even further, getting grants is very hard, even for very experienced and seasoned people. So here, becoming a reviewer for grants gives you also an idea. What is the framework? What are the relevant points? What do people criticize? And I mean, the other thing is clearly you need a research environment that is strong. And it doesn't have to be necessarily in the place where you are, but you need to look for mentors and role models. And mentors and role models are not always the same. A role model is, this is what I want to be, but they may actually be not nice people and not spend time with you. But at least this is where I want to be. A mentor is someone on the ground. Ideally, you have a mentor and a role model that are one person, but you may want, for different aspects, different mentors. You may need someone on the ground who helps you basically with your time management. Where do you put life? Where do you put clinical work? Where do you put making money? Where do you put research? And you may need another one who helps you write, another one who gives you ideas or is a content expert. And now with the internet and also going to meetings, you can approach people, and people who are, look for the most productive people that have a lot of papers and also write papers not always as a first author. You want people who are last, and let different younger people be first authors. Then you know they're generative and they're interested in helping you to grow and feel happy to actually have other people have their career and also enrich themselves. And those people you can approach after a talk or during a conference, and see whether they're interested in maybe co-mentoring you. They obviously need something from you too. They're very busy people, but if you basically stick to a process of collecting the data or writing something up, you can forge a lifelong relationship with these people. And I've had several people who have enriched me enormously, and I've helped them. So we grew together in order to be highly productive And also I'm learning now from some of my mentees new models of care and new models of data acquisition or data analysis. But another thing that really helped me also, and I learned that the hard way, was you need to know your statistics. So my first paper, which was the second paper, was in the American Journal of Psychiatry. I relied, this was legacy data, we analyzed it from a clinical trial, and I relied on the statistician, who was actually not a statistician, she was a psychologist. And she misrepresented the data. So I interpreted the data, and she's a co-author, she read the paper in a certain way, and it wasn't entirely right. So this was very important data, like early non-response predicts later non-response of antipsychotic treatment and psychosis. So people used that for the journal club. And then they emailed me and said, well, we analyzed your paper and we discussed it. This doesn't make sense, does it? And it didn't make sense. They were entirely right. Had I looked at the data myself, I would have seen it right away. But I didn't, because I didn't know statistics at the time. So that taught me early on, I need to be able to analyze my own data. And it's no rocket science. It's just chi-square and a t-test and doing a logistic regression and a linear regression, those four things, and obviously frequencies. That's very easily learned. I do JUMP, which is a SAS-based program. Others do SPSS. I really recommend that you learn those basic skills because A, you really understand your data, and B, different questions come up by interrogating your data. So that made me a far better researcher, knowing my data, analyzing them, but also a better reviewer and a better designer of studies because I had a statistical understanding of what an effect size is, what an outlier means, and basically what the strength of the data and the weaknesses are. So whatever, if you do research, know your data. And furthermore, you're not dependent on someone. If you want to submit quickly an abstract for a poster meeting or whatever, you can just do it yourself. And by looking at the data, you understand the data better. So that taught me a lot. You need to know your data.
Gotcha. In terms of data, did you ever use qualitative data as well, or mostly?
So I took the way of quantitative research, and not only my own, but I then also ventured into meta research, which is a great way of being a good methodologist, because you need to understand there are many bad meta-analyses because people just put everything in and push a button, because meta-analytic programs are pretty easy, but you need to know your data, what to put in, what to exclude, which sensitivity analyses you do to rule out bias, which subgroup analyses to do. And for that, you need to be a good methodologist. But you understand the field. And even when you meta-analyze areas where there's little research or not so good research qualitatively, you can then make recommendations for the field. This is what we need to do after you've systematically assessed the data. So I would say that nowadays, nobody should do a narrative review. It should all be a systematic review. And if it's enough data, then make sure that you have someone who can help you with doing this quantitatively and making this into a meta-analysis. And then there are meta-analyses. When you have many meta-analyses, you can do a meta review, which is an umbrella review, and you can even go to a parachute review of multiple umbrella reviews, and then even an atlas. So there are multiple methodologies, but you can then understand the field much better and set a tone for the field. So I think meta research also cuts down. You don't need funding necessarily. You just need time and expertise. You don't need to submit a protocol generally. You don't need, or you can nowadays you want to pre-specify it, but it's not like an ethics protocol, and you don't need to have any patient recruitment. So you basically take multiple studies that have been done, but you need to weed out positive from negative. or high quality from low quality. Now, can you do qualitative research? You can. That's not my expertise. I think it's more hypothesis generating. It obviously can be helpful to also bring the patient in, but I'm very much for measurement-based care. So even patient-reported outcomes don't necessarily need to be quantitative. But if there are areas where we have no good understanding of it, then qualitative research can also be one route that you can obviously venture into.
And I was reading that throughout your career, you've had like over 900 publications. You've also been awarded many, many awards. You are one of the top cited in terms of, I think it was like expert, you're top cited in, sorry, I think they're going to edit this video too. But it was like top cited for certain topics, and then right, sorry, I should have had this pulled up. Yes. Oh yes. So okay, they split. So I also saw that you were top cited as an expert as well as a world expert, because you are among the top 1% of the cited scientists in 15 topics, and then also of the 0.1% cited scientists in 24 topics. So with all of these accomplishments throughout your career, I was wondering if there was a moment that kind of stood out to you or stands out to you as a moment that you're most proud of.
Well, there are many, but to pick out maybe two or three, the first one is a 2009 paper in JAMA, not JAMA Psychiatry, for a project that I started without any funding as a fellow. Again, being driven by the research question, what is the effect of antipsychotics in children and adolescents who are starting antipsychotics? And at that time was the largest antipsychotic naive sample in the world, where patients naturalistically got aripiprazole, olanzapine, risperidone, quetiapine. And we saw that all antipsychotics, even the lower risk aripiprazole, caused a lot of weight gain and very early on in everyone. But at the same time, there were differences in the metabolic profiling depending on which drug they have. So weight didn't always mean metabolics. So I did this fully self-started without any funding, going to families' homes at 6 a.m. to draw blood, fasting, every Saturday and Sunday, getting families back in, because it was a study where we had monthly assessments for 3 months and then 3 monthly assessments thereafter. So I spent a lot of my time and had some funding then for one research coordinator that helped for some of the assessments. So for the first of the 1,000 patients, first 500, I recruited almost everyone in the evening when the families came back into the evening to the unit, and the clinical team had decided an antipsychotic was started the next morning. Then I was trying to consent them. So I worked my butt off to get this done, and it was a JAMA paper. And since then, 15, 20 papers have come out of this, and we can still harvest this. So that's one thing that I'm very proud of, because I started early. I saw that coming from the clinical experience, and I followed this through and put a lot into it. But what I'm also very proud of is several of my mentees that basically met me at meetings and said, can I be like you? Or what do I need to do to be successful? Now, well, let's do it together. Who have been very, very successful, more successful at their age than I ever was. And obviously my trajectory is not bad. So they will be even better. And I'm very proud of that. And yeah, these are my academic children, and it's so much fun to see them flourish and work with them and discuss data, and to have that legacy with certain people. And there are others, unfortunately, that then left research. Many people started and left for various reasons. They wanted to make money, they wanted to have a family. It's not easy to blend everything together, But those that are still working with me and are doing very well academically, it's really fun. And then the last maybe accomplishment is, well, when stress happens, like the pandemic.
Yeah.
April 2019, basically, we were all obviously pretty affected by what was happening. And I and one of my main mentees, Marco Solmi, sat together and said, oh, there are all these studies sprouting up and people are asking us to continue or to participate, but they all have flaws and we can do better. So we started our own study, even though it was like really uncertain what would happen. And we had someone sitting in South America, someone in Europe, and someone in Greece. So every night for basically 2 months, we met between midnight and 4 a.m. and hammered out the study. And then we had 230 collaborators and 180,000 participants in this online study out of 155 cities, countries. So nowadays, I mean, my strengths become also my weaknesses. I'm obviously want to paint the whole picture. I should have published with all of us a year into the pandemic. Now nobody's interested anymore, although we have a fuller picture. It's very hard to get it published. But I mean, this accomplishment at a time of immense stress, to get a research network together within basically a week, we went from 2 people to 40 people and then 200 people in another month. We got this in 2 months through the IRB and started our study online. That was quite something. Again, I learned the hard way that if it's a dynamic event, publish early. Don't try to have the full picture. But those are maybe the 3 main things that I'm most proud of, or I learned the most from also.
Yes. That all sounds amazing. I feel like your whole career, like I'm sure there are like episodes and situations that happen that have both fond memories as well as like some things that, like you said, you learned from. So yeah.
Oh, I love learning, and research is your secure road into lifelong learning, because you're never done, and it's stimulating. You're also together with smart people who bring up different ideas. That's what I cherish about research the most.
Yeah. How do you stay motivated? Like, it sounds like there are a lot of things that you're interested in, but has there ever been a time where um maybe you've come into like a rut and things kind of plateaued? How did you overcome that, stay motivated and like continue to grow in your career?
Well, I mean, there are many moments where I feel like I can't do it anymore. It's too much, because there's no plateau. It just goes up and up and up, and you have to learn to prioritize. Um, Emails kill me. It's just too many of them to organize everything, and so you have to really be able to organize yourself as much as possible, delegate, reassess the priorities in your life, but also in research. Find good people that you can then not micromanage, but macromanage after a while. So I've had to evolve as a leader and also as a leader of a team. I'm now a chair. I never wanted to be a chairman. I'm a researcher, but going back to Germany 7 years ago, I have to be a chair. Otherwise, people tell me what to do. So now I have to do clinical work, teaching, research, and administration. So it's the 4 legs I need to stand on. So navigating this is hard, but I think you reinvent yourself and you learn to master the new situation and then minimize inefficiencies. I've become more and more efficient every time, and also trust people that you can trust. People are the problem and the solution. Try to have more solution people with you, and identify problem people early, that you don't associate with them for too long. So I think those are all learnings to overcome some of the lulls. Big drawbacks are always when you don't get a grant. Yeah, you work so hard and so long and so much on it, and then it's nothing. Once you have a paper or a study, you can get it published somewhere. You lick your wounds when it was rejected, but it will find its home. But a grant, when life stands still and then you don't get it, that's tough. So those are clearly situations where you have to then reevaluate what's the next step. When you don't have funding, where do you go from here? I mean, I've been very fortunate to be in an environment where I've always been able to fund myself and also a big group, but that's not always the case. When you reach those lulls, you have to see, where do I go from here? And hopefully not get discouraged. I have this burning desire to solve problems and to improve patient care. So that holds me over, and I'm always able to find a new way, and obviously have also mentors and mentees that keep me going. So I also feel now responsible for a group of people, so I can't just stop, nor would I want to, because it's fun. I mean, I learn so much and I can contribute. That's another thing. I feel I could never see as many patients in my office and influence their lives as I can with research. So a research finding that is really relevant and clinically salient will influence the care of so many clinicians and patients, and that's totally rewarding.
That sounds amazing too. I have another question. So, what are you looking forward to, and what is exciting in terms of the field of psychiatry and like emerging research? And then also wondering about what what are next steps for you in terms of your own research?
Yeah, I mean, I would love to see biomarkers, stratified or personalized psychiatry, precision psychiatry, but I see this more distant. The immediate excitement comes from new psychopharmacology. And we have some revolutions happening right now in front of our eyes. Unfortunately, these are old mechanisms that we're rediscovering, but be it as it may, we will treat patients that are not served well with current treatments better. So, for example, there's a revolution in psychosis treatment with muscarinic agonists. So the acetylcholine system intersects with dopamine, with GABA, with glutamate, and then go dopamine can help psychosis presynaptically, where we think the problem is. We've always looked for or had a postsynaptic dopamine blockade solution for a presynaptic hyperdopaminergic problem. Now we have presynaptic modulators, either via acetylcholine and dopamine or via GABA, glutamate, and dopamine. That's totally exciting. So 26th of September 2024, the first muscarinic agonist will be approved by the FDA. That's great. And there are 4 or 5 that are being developed. So I'm very excited about that, and I'm fortunate to be part of that development. On the depression side, we have now the psychedelic antidepressants, so 5-HT2A agonist. I think this is a stepping stone. We don't need psychoneuroplastogens. We need neuroplastogens without the psychotomimetic effects. And the same on the NMDA side, where obviously ketamine and esketamine are the front runners, but modulating these non-biogenic amine systems to treat patients that are currently not helped well enough. That's really exciting to me. Then also PTSD and OCD and other conditions that are potentially being helped better. We've also come some way with psychotherapies and interacting or doubling up on psychotherapy with psychopharmacology. That's exciting. I've been part of some more global psychotherapeutic programs in Europe, like the Mind My Mind program, where people children and adolescents with subthreshold symptoms got modular CBT and could be helped in not developing further externalizing or internalizing disorders. So that's also exciting to me to combine psychopharmacology and psychotherapeutic interventions. But yeah, that's the next step for me, doing more meta research, pulling things together with novel methodologies, but also novel mechanisms of action of psychopharmacology that hopefully will change the trajectory of the illness for some patients.
And I'm excited to learn more about that when the studies and when the medications come out too. And then yeah, I want to be mindful of your time. My last question was going to be like if you could share one piece of advice for trainees, but you kind of did that throughout the interview.
No,
And-
I have even a PDF file where I have lots of advice on how you write a paper, how you get a grant, and what you do to be successful in research. I can send it to you if you're interested. But
yes.
some advice:
Mhm.
no book chapters. Save your time.
Okay.
Books are part of the. This is obviously very subjective, but if you ever write a book chapter, it has to become a paper. Book chapters are not cited. You need citations, you need name recognition, you need your H index to go up. So that's one thing. In the beginning, do lots of reviews of papers. When you're mid and later career, don't do many reviews anymore because you need to do your own research and help other people be successful rather than manage people's research at the journal level. No journal editor position because that takes time away from your own research. I personally also advise people not to go into political science. So I take very little positions in any organizations because if you want to do research, do your research rather than organizing meetings or being like on the stepping ladder. There are many people who like that, but I want to say if you want to refine and retain your time for research, basically don't do that. And then also you need to always reprioritize. Think what's important to you, what's important to your career, but also to your life. You need some work-life balance because otherwise you burn out. Whatever keeps your candle burning obviously needs to be there, but also you need a balance. I think that those are some of my big points of advice. And find good mentors, mentees, and some role models where you want to be.
Thank you so much. It was such a pleasure speaking with you, Dr. Correll.
Same here, Grace. Really wonderful talking to you.
Yes, thank you, thank you.